Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of the Fellow on Call HemOnc podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we continue on our AML journey, this time talking all about consolidation and maintenance therapy.
Excited to get into this one. We've actually taken a time off from recording. It may not seem that way on the way the releases are happening, but Ronak finished his boards, Dan went on vacation, a lot of cool things happened, so it's kind of nice getting back together with these guys and recording another episode. It's been a while.
Yeah, it is. And, I think this is going to be a good one, too, because it's important to touch on, you get somebody into remission and they think, well, okay, great. I'm in remission. Why do I need more chemo? And this episode, I think, will be important to outline why we do this and what it is that we do.
Completely agree. And I am excited to be back and getting back into the swing of things. So without further ado, guys, why don't we roll that show? So I feel like we need to start today's episode with a little bit of a disclaimer that if the sound abruptly goes out or you hear, I don't know, like a boom-like sound, there's a very good chance that it's Vivek that's responsible for this. Do you want to kind of give us a little bit of insight as to what's going on in your house, Vivek?
So apparently, long story short, we have a gas leak. So essentially, we smelled gas earlier today a little bit. I still cooked some breakfast. I was like, yeah, it's probably fine. I think this is just, I don't know, the heat's turning on, it's gas power, it's just a little bit of faint smell. Definitely didn't go away. And then my wife's like, no, we need to call somebody. So we called somebody, and the dude, he's actually here right now. He measured it, and apparently it's 900 parts per million, but you don't need to evacuate until 10,000. So I think we're good. He said he can fix it. Luckily, I have a wonderful wife who's dealing with it all right now. So am I an idiot? Yes, but I don't recommend anybody else doing this. But because apparently you're like not supposed to use your cell phone and all this other stuff when you smell gas. So definitely did not follow instructions. So if something happens, then we all know never to do this again.
Yeah, good luck. I feel like that could be pretty serious. So hopefully he's able to find that soon.
I have faith.
I have faith too. And so maybe we'll just jump right into that episode just to make sure that we try to cover as much as we can before Vivek gets pulled away to deal with a potential gas-related emergency. Guys, the last few episodes that we had recorded, we were talking all about that induction phase of AML treatment. So we went through the ins and outs, talked about all the different treatment options, the data behind it, how we decide what regimen to pick over another, and even talking about things like the differences between treatment paradigms here in the US versus in parts of Europe. So really awesome series of episodes. Listeners, if you haven't listened yet, please go check that out. And today we move to that next discussion point when our patient is out of the hospital, they see us. Sometimes, I guess if they're sick enough, they'll still be in the hospital. But usually these conversations are happening, at least initiated in the outpatient setting. And we sometimes as trainees don't get a lot of insight into that. So I'm excited to talk about consolidation and maintenance and how we decide what we do with our patients after that initial induction period. So Vivek, do you want to start us with a case of a patient I believe you had seen?
Yeah, let's go through this. This is a recent patient of mine. So we have a 60-year-old female with a history of triple-negative breast cancer diagnosed 10 years ago that was treated with neoadjuvant dose-dense ACT, mastectomy with lymph node dissection, and adjuvant radiation. And she presented to the ED with severe fatigue and found to have pancytopenia. Her CBC with differential was notable for a morphologic concern for circulating blasts. She had peripheral flow cytometry sent, which confirmed circulating myeloblasts with an abnormal immunophenotype without concern for acute promyelocytic leukemia. A bone marrow biopsy was performed the next day, and it confirmed a diagnosis of AML with 60% myeloblasts by aspirate manual differential. Like we talked about in our previous episodes, and again, check those intros episodes out if you want to get a more comprehensive outlook on all of this, but FISH was sent, which showed rearrangement in 11q23 with translocation 911. Initial molecular studies were negative for NPM1, FLT3 ITD, FLT3 TKD, IDH1, IDH2, and a BZIP in-frame CEBPA mutation. So this would be defined as therapy-related AML with a KMT2A rearrangement. So remember that 11q23 is that MLL gene KMT2A rearrangement. And because she had the treatment-related AML or this therapy-related AML, she was started on Vyxeos, also known as CPX-351, which we talked about in our previous induction episode. And a few weeks later, all of her studies came back from the bone marrow biopsy, and we found out she had a complex karyotype, and NGS was notable for an ASXL1 tier 1 mutation. Remember to check out our prior episodes again on this initial workup and how we define AML by recurrent cytogenetic abnormalities or recurrent genetic abnormalities when appropriate, and we'll link another helpful diagram to our show notes of this episode. Her induction course was complicated by recurrent neutropenic fever and prolonged count recovery requiring 45-day hospitalization. She has now achieved a CR on a bone marrow biopsy after count recovery with less than 5% blasts. So we're talking to her now about thinking about an allogeneic transplant. We sent off HLA typing when we knew that she was in this intermediate risk AML subcategory. So can we start off with who we should consider for an allo transplant who has AML?
Absolutely. This is a really important branch point in figuring out how we're going to treat somebody. So you're kind of figuring out early on who is going to be tracked towards transplant and who's not. And that's both the combination of the risk of their disease and who they are as a person in terms of their fitness for this. So our first step is really to determine whether or not a patient could undergo allogeneic transplant. Are they fit or unfit for intensive chemotherapy induction and then the allogeneic stem cell transplant process for curative intent? It's a very subjective evaluation, so stay tuned for an upcoming episode where we're going to discuss this concept in a lot more detail with a transplant physician. But it's, suffice to say, a complex process that you kind of have to look at the person as a whole and evaluate all their organ function. There is a clinical score you can use, an HCT-CI score, that helps risk stratify patients for transplant-related mortality, but there's still a significant amount of clinical judgment that goes into that. So let's focus on patients who are, in fact, fit for intensive induction and transplant. Once we determine that a patient could tolerate that type of therapy, we then risk stratify patients based on the ELN 2022 risk groups into favorable, intermediate, and adverse risk. The short answer is that we transplant patients who are intermediate or adverse risk and not favorable risk. To recap some stuff we talked about in our prior intro episode, you should think about treatment in 3 phases. The first is induction chemotherapy, where we give high doses of chemo to induce a morphologic remission defined by less than 5% blasts on the bone marrow biopsy after count recovery. The second phase is consolidation. We know that even if we can't see the blasts on the morphologic evaluation of the bone marrow, there's still some leukemic cells left over after that induction phase. So we need to deepen that remission with additional rounds of chemotherapy to prevent relapse. We usually use a less intensive form of chemo, typically based on cytarabine, with the goal of deepening that remission. For favorable risk patients, we kind of stop here. We give them their chemo and then we observe. And now we can even assess for measurable residual disease, which can help tell us if we need to move to phase 3, even for favorable risk patients. And that third phase is maintenance phase. Although it feels a little bit strange to call stem cell transplant a maintenance therapy, the idea is, it does sort of help transition between consolidation and maintenance, I guess you could say. Allogeneic stem cell transplant in this third phase is where we ablate the patient's bone marrow with very high doses of chemotherapy and then transplant in another person's stem cells. So that's the allogeneic part. It's coming from another person. They'll then have a new immune system and hematopoietic system, which we call the graft. And the graft will fight off any residual leukemia that was left behind, even after that ablative dose of chemotherapy. We term the graft versus leukemia effect. We have to balance that therapeutic benefit of the graft attacking the leukemia with the graft attacking the rest of the patient's cells, which we call graft versus host disease. And so patients require some degree of immunosuppression to reduce the risk of that GVHD, graft versus host disease. The balance that you need to strike is minimizing that immune suppression as much as possible to allow that optimal graft versus leukemia effect while not letting graft versus host disease flare, which can lead to significant morbidity and mortality over the long term. So super delicate balance. It's something that we're constantly improving, but that's the gist of these 3 phases of therapy and how stem cell transplant sort of fits in.
Yeah, that was a great recap, Dan. And I think in this episode we're going to be focused. We talked about induction already. We're going to be focused on the consolidation phase here, as well as this allogeneic transplant. And we kind of think about it here as sort of a quote unquote maintenance, because this graft versus leukemia is like maintaining your remission in the very long term, right? And so that's a really important concept that you mentioned. So as we discussed in our induction therapy episodes, patients with secondary AML from either an antecedent myeloid neoplasm or related to prior chemotherapy had poor historical outcomes, with long-term overall survival around 20 to 30%. And this is because these patients are often in the adverse risk group. When you really look at their cytogenetic and molecular studies, it tends to be that they have some of these higher risk genetic features. And those are the most important factors, again, when determining the need for allotransplant, not just the fact that they had prior therapy. That's really important. You need to actually look at their molecular studies and their cytogenetics. So, Ronak, you're fresh off the board semi-recently. Now, board-certified hem-onc doctor here. What are the common cytogenetic abnormalities that we see with therapy-related AML?
And for some reason, even though realistically we can always look this up and we should look this up, right, whenever we get the NGS report back, the test writers seem to really like this topic. And hypothetically, if I was to take this exam again, I would make sure that I spent some time reviewing these cytogenetic abnormalities that I'm going to mention. So for anthracyclines, we often see a rearrangement involving 11q23, which is known as the KMT2A or an MLL rearrangement. And you often hear that this occurs 2 to 3 years after treatment with an anthracycline, which helps you remember the Q23. MLL stands for mixed lineage leukemia, and for alkylating agents and radiation, we often see deletions in chromosomes 5 or 7 and potentially a TP53 mutation. So you will hear that this occurs 5 to 7 years after therapy, which helps you remember 5 and 7. Bottom line is that clinically this doesn't really matter, but it does help us to risk stratify our patients. And again, for the purposes of test taking, not that that's the goal in life, but one that we have to, overcome, it is important to be aware of these cytogenetic changes. So with that in mind though, Vivek, like going back to our case, we have this fit 60-year-old patient. She is in CR after induction with Vyxeos, and she doesn't have a good sibling match, let's just say. And so there's this donor search that's ongoing, and she hasn't yet found a match. And so we're planning on proceeding with consolidation cytarabine at a dose of 1.5 grams per meter squared on days 1, 2, and 3. So as our historian, I was curious, where did this consolidation approach actually come from?
It's time for another historical lesson from the fellow on call, where maybe a lot of people skip fast forward, but here we are. It's actually, this one is actually really, really important, because it's all over the place, and understanding this historical perspective will really give you an understanding about why different providers do different things, and also some limitations in some of the clinical trials that you'll see. So the short story is that you definitely need cytarabine-based consolidation, but there is no good prospective evidence on the optimal dosing approach or frequency that this should be given. So remember from our previous episode that we had the introduction of 7+3 standard of care chemotherapy with daunorubicin and infusional cytarabine from a pivotal study published in 1973 with CR rates around that 60-65% range. After that time, though, there was uncertainty in what do we do? How do we keep these patients in consolidation? Because they all relapse. What do you do? What's this post-remission consolidation therapy? What maintenance therapy do you need? And there were 2 pivotal cooperative group trials run in the early 80s that really said we need to do something. One was done in the ECOG group in the United States in a study called E3483. Don't worry, we'll link all this to our show notes. And essentially, patients who had achieved remission after induction with that daunorubicin cytarabine and did not have a matched sibling allotransplant donor, because back then we really just did matched sibling donors, they were randomized to 1 cycle of high-dose cytarabine, maintenance chemotherapy, or observation. The observation arm, meaning I got a remission, I'm doing nothing else, was terminated early because literally every patient relapsed by 18 months, and a vast majority relapsed within the first 6 to 12 months. So it said, you need to do something. Doing nothing is an absolute no-go. Another similar trial was done in the German AML group in 1978, and that showed the same results that in the observation group, they had an observation arm in that trial. literally every patient relapsed. So you need to do something after remission. Sounds great, 65% remission rates. This is also the problem with surrogate endpoints in AML. Clearly hitting a CR is not predicting your long-term remission and your overall survival. You need to look at something way past just achieving a CR. So these studies really showed that durable remissions occurred in less than 20% of patients overall with the consolidation and maintenance approaches that were used. So the thought was, how can we do better? What can we do here? And around the same time, high doses of cytarabine were used for relapsed refractory leukemia patients. And there were several dose-finding studies with testing 1 gram per meter squared up to 7.5 grams per meter squared, different lengths of time on the cytarabine. And the question was, what's the maximum tolerated dose for these patients? What can we give them? They can tolerate the cytarabine and effectively put their relapsed disease into remission. And what they found was cerebellar toxicity, which was the big concern with cytarabine, is that you develop this irreversible cerebellar toxicity that occurs about a median 5 days after you initiate the therapy. That really occurred at doses above 3 grams per meter squared. So it said, okay, this is the cap. And then the other thing that was found was the length of time on cytarabine was associated with other toxicities, GI toxicities. There's ocular toxicities with keratitis that we have to give dexamethasone eye drops to these patients for. And they found that Q12 dosing for 6 days maximum was the sweet spot with that. So that really led us to understand what these dosing strategies should be and what the maximum tolerated dose of that 3 grams per meter squared should be. And then it was after that time that there was a pivotal study done by the CalGB study group, the CalGB Cooperative Study Group, that was published in New England Journal of Medicine in 1994. And that's really led to what we currently do with HiDAC consolidation, high-dose cytarabine, also called HiDAC consolidation for these patients. And what they did was they took patients who all got 7 and 3, and they're randomized to 3 different consolidation strategies. Continuous cytarabine for 5 days at 100 milligrams per meter squared, continuous cytarabine for 5 days at 400 milligrams per meter squared, and high-dose cytarabine, also called HiDAC, at 3 grams per meter squared, given every 12 hours on days 1, 3, and 5, with monthly cycles repeated for a total of 4 cycles. So each of these patients got 4 cycles of consolidation, and then after that, they went on to receive monthly anthracycline and low-dose cytarabine, so even more therapy after this consolidation. And this was that first pivotal trial. And what they found was that HiDAC was superior to the other consolidation strategies with a 4-year disease-free survival of 46%. So that was pretty good. It improved on that 20%, that 20 to 25%, all the way up to 46%. And this led HiDAC consolidation, high-dose cytarabine, what we call HiDAC, for 4 cycles, technically followed by monthly daunorubicin and low-dose subcutaneous cytarabine for 4 additional months as a standard of care treatment option. One important limitation in that study that was found is that after 4 years of opening the trial, patients above the age of 60 could not tolerate HiDAC consolidation at all due to severe ocular toxicity, neurotoxicity, and infectious complications. So this really led for the next several decades where many trials were really only looking at patients younger than 60 because these older than 60 couldn't tolerate this dose. And even for those younger than 60, only about 50% of them, 50% of these young patients only, could tolerate all 4 cycles. But this was in an era without the dose adjustments we use now and things like G-CSF support. So that up to that point, that really led us to the backdrop of the therapies we have now. So to continue on to that, can one of you guys really talk about how did we get to 3 cycles of HiDAC without further chemotherapy? Because at this point, what we had was we found the dose, we found the frequency, and then we had this pivotal study that really said, hey, only for patients younger than 60 could they even tolerate this. And they did 4 cycles of HiDAC, high-dose cytarabine, followed by 4 more chemotherapy cycles. So how did we get to what we see nowadays, which is 3 to 4 cycles of high-dose cytarabine?
Well, there was another important CalGB study published in Blood in 2005 that demonstrated the efficacy of HiDAC times 3 cycles without further chemotherapy. In this study, patients started out with 7 and 3. Daunorubicin was dosed at 45 milligrams per meter squared. And if they had complete remission after induction therapy, they were randomized to 3 cycles of HiDAC at a dose of 3 grams per meter squared versus 1 cycle of HiDAC followed by intensification with Cytoxan and etoposide for 1 cycle, and then mitoxantrone plus AZQ or diazoquone for another cycle. 3 cycles was chosen for HiDAC just to mirror the treatment length as opposed to the 4 cycles in the previous study. So really, the new thing they were comparing it to was this dose intensification scheme, and they just wanted like to like. They wanted 3 cycles in each experimental arm. There was no difference in disease-free survival or overall survival between these two approaches, and similar results when they looked back and compared survival to 4 cycles, followed by more anthracycline-based consolidation. And so that led to 3 cycles of HiDAC to become a standard of care option for consolidation therapy. One of the most important findings in this study was that there was a tremendous benefit of HiDAC seen in those with favorable risk cytogenetics, which is defined by core binding factor AML, so that T821 inversion 16, or translocation 1616, with a 5-year overall survival of around 70%. Super high 5-year overall survival for just consolidation therapy. So that was another really important conclusion that came out of this trial, that maybe we can stop at consolidation therapy alone and not go on to transplant in folks with this favorable risk cytogenetics. A few years later, in 2011, there were 2 other studies, one run in Japan and one run by the French group, which randomized patients to HiDAC for 3 cycles versus multi-agent chemotherapy consolidation without high doses of cytarabine. The Japanese trial showed no difference in disease-free survival or overall survival, but noted a higher rate of neutropenia and infections in the HiDAC arm, because at that time, G-CSF support was not being broadly used. The French trial showed no difference in DFS or OS, but a much better toxicity profile with HiDAC compared to chemotherapy, so a little conflicting. The last question to settle is HiDAC alone versus HiDAC with multi-agent chemotherapy. And this question was addressed by a German trial published in 2013 called the AML 2003 trial. Patients were randomized in consolidation to HiDAC for 3 cycles versus HiDAC plus anthracycline-based chemotherapy. And in this trial, there was no difference in 3-year DFS or OS, but again, a much higher toxicity profile in the combination arm. So this was just more evidence to support that HiDAC consolidation really is the standard of care. So that's kind of how we got to this 3 cycles of HiDAC, seeing that 3 cycles was similar to historical rates for 4 cycles, and then kind of comparing with or without multi-agent chemotherapy and seeing you really just are getting more toxicity without any real benefit in DFS or OS.
It's always good to know how we got to these regimens, and for AML, this is particularly important because some people prefer 3 grams per meter squared, but others prefer lower doses. And as you can see with what I'd laid out initially and then what Dan picked up on after that, is that there are so many trials that really looked at this higher dose of 3 grams per meter squared, knowing that we're really only looking at patients younger than the age of 60. So you'll also see different schedules. In these studies that we had mentioned, it was day 1, 3, 5 for a lot of them, but you'll also see this day 1, 2, and 3. And again, check out our website and our show notes to follow all this data summarized. But before we get into this lower doses, other than this 3 grams per meter squared, what's the data behind G-CSF use and the condensed days 1, 2, 3 schedule and consolidation as opposed to days 1, 3, and 5?
So after that pivotal CALGB study in 1994, high-dose cytarabine in consolidation was pretty much how every trial proceeded moving forward for patients younger than 60. But, one major issue that we sort of alluded to already was that there were higher rates of infectious complications and febrile neutropenia and prolonged myelosuppression in a lot of these trials. And so there was also no standard for patients above the age of 60, as we've been alluding to. So there was a push to trial different schedules and lower doses and even incorporation of growth factor support. So G-CSF was incorporated into many trial protocols as a means to minimize that duration of myelosuppression. The NCCN guidelines for many years actually didn't even recommend G-CSF support outside of clinical trials, given the concern that it could stimulate leukemic blasts, leading to relapsed AML for those who had achieved a CR and lack of prospective evidence of efficacy. But there was a Cochrane meta-analysis from 19 randomized trials in AML published in 2012 that did not show a benefit in infections or survival with the use of G-CSF for AML treatments. This was limited, though, because of the inclusion of induction, consolidation, salvage, or conditioning prior to autologous transplant studies, with the majority having multi-agent chemotherapy arms. And it was still unclear whether there was any benefit in HiDAC consolidation arms with a recovered marrow. There was a pivotal study from the German-Austrian AML study group that was published in Blood Cancer Journal in 2017 that showed the efficacy of incorporating routine G-CSF in consolidation and HiDAC dosed on consecutive days. And so this was a sub-cohort study from multiple randomized trials running at the same time in Germany and Austria. Patients were randomized to consolidation arm receiving either HiDAC consolidation at 3 grams per meter squared every 12 hours on days 1, 2, and 3, or the same dose on days 1, 3, and 5. And in addition, they received pegfilgrastim or no growth factor. So there were 392 patients who got HiDAC on consecutive days and 176 patients who got HiDAC on days 1, 3, and 5. When they compared the schedules, the consecutive day 1 to 3 group had significantly lower infections and transfusions with faster count recovery. And the use of G-CSF was associated with significantly lower infections and faster count recovery. And so there was also reduced hospitalizations and lengths of stay with the condensed schedule and the G-CSF support. Most importantly, there were no differences in relapse-free survival or overall survival, which really shows that this schedule and the use of G-CSF is safe.
Yeah, and Ronak, that's really important that you ran through that. And it's crazy to me, the NCCN guidelines for years, and there's actually some attendings that we've all three of us have worked with before who say, I will never use G-CSF for support because of that one meta-analysis, which was so limited. This was including totally different patient populations. Some were salvage treatments, some were induction chemotherapy. Those are different marrows, right? If you have leukemia filling your marrow and you dropped 7 and 3 into it, maybe G-CSF isn't doing all that much in that patient. But when you have a recovered marrow in CR and you're going through consolidation therapy, at that point, we saw, like you mentioned, that G-CSF reduces the transfusion need, reduces days in hospitalization, decreases chances of infection. And also this condensed schedule, day 1, 2, 3, there's no prospective evidence, right? We don't have a prospective randomized trial, but in these sub-cohort studies where we had these ongoing randomized trials that they were leveraged to look at some of these questions, it really suggests that, hey, this condensed schedule, patients are in less time in the hospital, right? So in our case, we had this patient and she had this prolonged count recovery with that CPX-351, that Vyxeos induction, and she's in consolidation now. Let's get her out of the hospital in 3 days rather than getting her out of the hospital in 5 days with that day 135 dosing. Also knowing that her chance for recurrent admission is lower. So that's really great that, we got to those points. So the next question that comes up then, so for our patient here, we'd said 1.5 grams per meter squared, but we had just talked about how 3 grams per meter squared was really the standard. So where did these lower doses come from, and how do we get to the point where we can have decreased doses of this high-dose cytarabine?
Well, as you had talked about before, we knew that toxicity was very high for 3 gram per meter squared dosing, and many older patients just could not tolerate the dose. 60, that's a pretty young cutoff when we're talking about our modern patient populations. In addition, cytarabine was cleared in part by the kidneys, so additional dose reductions are really important for folks with lower renal function or just any degree of renal dysfunction. Again, very common in our older patients. And there were 10 randomized phase 3 trials between 1994 and 2016 that looked at a variety of doses and combinations of cytarabine and consolidation, but there were no prospective trials in that group that directly compared 3 grams per meter squared to 1.5 or 1 gram per meter squared. In 2017, though, there was an interesting network meta-analysis that took data from these 10 trials and tried to derive some comparison between HiDAC and IDAC. And for the purpose of that comparison, HiDAC or high dose AC was defined as cytarabine at a dose of 2 grams per meter squared or higher, and IDAC defined by a cytarabine dose of 1 to 2 grams per meter squared. Keep in mind that many of these trials may have combined cytarabine with multi-agent chemotherapy and consolidation. And they applied some fairly complex statistical methodology to try and perform these indirect comparisons with dosing. And the authors ultimately concluded that the addition of other chemotherapy was non-contributory, or they were able to adjust for it in some way. So the conclusion that they drew from their meta-analysis was that there was no difference in hematologic toxicities, but they found an inferior disease-free survival for the intermediate dose cytarabine when compared to HiDAC. The hazard ratio is about 0.87. They found that the benefit was most pronounced for patients with core binding factor AML and favorable risk cytogenetics. So those folks who might be good with just consolidation seem to derive the most DFS benefit from HiDAC. But remember, the problem with all of this is that we know that combination chemotherapy approaches and the differential use of allogeneic transplant are going to greatly affect these outcomes like disease-free survival. And so take this analysis with a grain of salt. We'll have a link to it, of course, in our show notes.
Yeah, and Dan, I think that was really great. And one of the things that's really important that you mentioned about that network meta-analysis is that when you're comparing these doses of cytarabine, there was also mitoxantrone, etoposide, cyclophosphamide. All of those things are definitely going to affect the hematologic toxicity. So you can't draw that direct comparison, whereas the prospective trial that you'd mentioned before from the UK really did show us that these intermediate dose cytarabines have some of these better outcomes in terms of the hematologic toxicities, the hospitalizations, the infections, and things like that. Though there is this caveat with this concern potentially for relapse, which we know can be clouded by who's getting an allo transplant and who's getting some of these therapies as in addition to the cytarabine consolidation. So in general, the way that we can think about this is that for patients above the age of 60, you should really treat them with this intermediate dose 1.5 gram per meter squared approach. And you may want to use that 3 grams per meter squared for younger patients who are fit, and particularly those for favorable risk cytogenetics, as you had mentioned. So I think that might be a good stopping point for this episode. What do you guys think about picking this up next week?
Yeah, I think so.
I agree. I think that's a great place to stop. It's just crazy to me that a lot of our reasons for why we do what we do, which I'm learning based on this discussion, is sort of based on meta-analyses and things like that, right? We're sort of basing a lot of this data and sort of putting it together piecemeal to try to come up with our current standards of care. So it is a little bit eye-opening because we talk about this all the time for management purposes, but really, really cool that we got to talk through all this data today for sure. So guys, until next week then, why don't we, I agree, let's stop here and then we'll pick right back up where we left off. So until next time, guys, we'll see you all later.
See you later.
Peace.